Hello, my name is Dr. Ram Gopal Krishnan. I'm an infectious disease physician at Apollo Hospitals, Chennai. And today I'm going to talk to you on meningoencephalitis. Now, what is meningoencephalitis? As the word means, it's an inflammation of the meninges and the brain. And how do we make a clinical diagnosis? Essentially, the quartet we look for is an acute onset of fever, seizures, altered mental status, and headache. And on physical exam, the patient typically has neck stiffness. Patients may also volunteer a history of photophobia, where they just can't look at a light without a feeling of discomfort. Meningoencephalitis is characterized by typical EEG and CSF findings, which are the cornerstone of diagnosis. And in this day and age, meningitis overall is declining, largely because of the rollout of vaccines like the Haemophilus influenzae type B vaccine, the pneumococcal conjugate vaccine. But still, when it does occur, mortality can be as high as 15%. So this can potentially be a fatal syndrome unless we learn to approach it, diagnose it, and treat it correctly. So what causes meningoencephalitis? The most common causes are either bacterial or viral. And as the slide shows you, the commonest bacterial etiology is the pneumococcus. Now, Haemophilus influenzae used to be common in an era prior to HIV vaccination, and meningococcus is still sporadic in India as opposed to the West, where it is much commoner. There are a few other causes of bacterial meningoencephalitis you need to be aware of. One of them is listeria, which typically affects immune-compromised or elderly individuals, and a couple of tropical entities which are unique to developing countries, tropical countries, such as scrub typhus caused by Orientia tsutsugamushi and leptospirosis, both of which can cause meningoencephalitis. Now, the large differential between bacterial meningoencephalitis is viral. And what are the common viruses that cause meningoencephalitis? You can classify viruses into three broad types. Number one is herpes simplex, which I put up front there because it's the only treatable virus among all these viruses that we discuss. Number two is enteroviruses, which typically are commoner in children and classically cause more meningitis rather than encephalitis. And number three are the arboviruses or the arthropod-borne viruses, which are typically transmitted by an insect or some other vector. And the commonest and most important among these in tropical countries would be common mosquito-borne diseases like dengue, Japanese encephalitis, chikungunya, West Nile encephalitis, and finally, in this day and age, SARS-CoV-2 can also cause an encephalitis syndrome. When it's not bacterial and not viral, that is when you consider other less common etiologies. For instance, this emerging autoimmune entity called anti-NMDA receptor encephalitis, and much rarer entities such as acute presentations of tuberculosis or fungal infections are down the list. So when you approach these patients, the first thing you need to decide is this bacterial or is this viral? So in order to give you a broad distinction of how we approach these patients from an early diagnosis and early therapy standpoint, the principles are: all bacteria are treatable with appropriate antibiotics. The only treatable virus is herpes simplex, and that is why it's very important to make this particular diagnosis. If you have a delay between presentation of the patient, then mortality goes up if you delay in diagnosis and delay in starting therapy. And this is true for both bacterial meningitis as well as herpes simplex encephalitis. And therefore, guidelines emphasize that you got to get your therapy going as soon as you can. In fact, as soon as the patient presents, provided you're planning to do imaging, lumbar puncture, etc., you don't necessarily have to wait till you do those by the time you give your first dose. So the clinical algorithm says if your clinical suspicion is high, go ahead and give your first dose and then proceed with your workup. If your clinical suspicion is lower, say other entities are possible, then you may want to do your tests first before you give your first doses. When do you need to do CNS imaging like a CT scan or an MRI prior to lumbar puncture? And the reason why we discuss this is because people with space-occupying lesions or elevated intracranial tensions, there is a risk of coning or transtentorial herniation if you do a lumbar puncture in them. So the situations where we recommend imaging prior to LPR, immune-compromised hosts. Number 2, if there is a focal neurodeficit, say loss of power in one arm or leg, or if there is papilledema. So it's very important to do a fundus exam on all these patients before you do a lumbar puncture. Now, there are some aids in how you approach and how you treat these patients. And number 1 is blood cultures. Now, blood cultures have to be done in every febrile patient who comes to the emergency, and meningoencephalitis syndromes are no exception. 2 sets of blood cultures when they come in. The cornerstone of diagnosis is CSF exam. So as soon as these patients come in, you either give them their first dose of therapy and you plan your CSF, or you plan your CSF first. And the tests that are mandatory are the CSF cell count, which is the most important factor, the CSF biochemistry, and the gram stain and culture. And it's always appropriate to set aside a volume of CSF for further tests, including molecular diagnostics, which may or may not be required later. Other tests, such as a serum procalcitonin, a peripheral white blood cell count, are always done in the workup of any septic patient, and meningoencephalitis is no exception. These may sometimes guide you towards a bacterial or a viral etiology. Now, this just tells you an automated multiplex PCR system is often used for the diagnosis of meningoencephalitis syndromes. These are especially useful in the situation where bacterial meningitis has been treated with antibiotics elsewhere, so you're not going to get positive cultures. Or in the case of viruses, for instance, herpes simplex is picked up both on a multiplex as well as a standalone PCR, and these tests are very useful, especially in the diagnosis of viral syndromes. So this is your approach to an acute meningoencephalitis syndrome. Your clinical diagnosis is meningoencephalitis based upon the clinical features which we have discussed. You get a CT scan if there is immune compromised, if there is a focal deficit, or if there is papilledema. And if any of the above is true, while you're waiting for a CT scan, you may want to give a single dose of dexamethasone. I will tell you why shortly. And a single dose of antibiotics and acyclovir after drawing blood cultures. And once your imaging tells you that there is no raised intracranial tension, no risk of transtentorial herniation, then you can do your lumbar puncture safely. So what are the principles of therapy in these patients? So that depends upon the organisms that you are targeting. And the number 1 organism in terms of meningoencephalitis is the pneumococcus. It's the most virulent. It's also the one that can be readily cured if you are treating these patients early. Number 2 is Neisseria meningitidis, which is falling in incidence as opposed to the pneumococcus, and Haemophilus influenzae once again used to be a problem in children, but with the advent of vaccines is far less common. Listeria, this is important because you will require specific therapy, namely ampicillin. Think of this in immune-compromised hosts or elderly hosts. If it's a neonate, then group B strep, which is typically acquired from the mother's vaginal flora during the birth process, is one of your target pathogens. And finally, diseases endemic in India. For instance, scrub typhus or leptospirosis require specific therapy because the standard beta-lactam antibiotics we use for meningitis will not usually cover these organisms reliably. Now, one of the main issues that you need to address when you treat pneumococcal meningitis, either empirically or after receipt of cultures, is the organism sensitive to penicillin? We all know that historically, pneumococcus has been sensitive to penicillin, but in the last 20 to 25 years, there's been increasing resistance. This is especially a problem in the West. But in India as well, we have this problem as illustrated in this recent paper published a couple of years ago. It is also important to appreciate that the definition of sensitive versus resistant depends upon where this pneumococcus is isolated from. If it's a CSF isolate, then note that the cutoff for sensitivity for sensitive is actually much lower. It's 0.06. On the other hand, if it's a systemic isolate, then the cutoff is much higher, and it also depends on whether you're using oral or parenteral antibiotics. Obviously, in meningitis, you would use parenteral antibiotics alone. So it's important to remember that pneumococcus from the CSF has to have a very low minimum inhibitory concentration to either penicillin or ceftriaxone for us to call it susceptible. Otherwise, it becomes intermediate or resistant. So how do you pick your antibiotics? Now, the vast majority of pneumococci in India would be sensitive to ceftriaxone, at least 95% would be. But to cover those remaining 5% of isolates that are either intermediate or resistant, you would need vancomycin. So the combination of vancomycin and ceftriaxone is the initial empiric choice to cover pneumococcus. And obviously, this will cover meningococcus and Haemophilus influenzae B quite reliably. You would need doxycycline, especially if there is a risk of a tropical infection. The appropriate epidemiology is there in terms of a water exposure or an insect bite, for instance, an eschar. And the drug of choice for Orientia or Leptospira is doxycycline. Ampicillin, if your patient is elderly or is on cancer chemotherapy or any other form of immune compromise to cover listeria. And the only treatable virus is herpes simplex, for which you should always include acyclovir. Once you get your cell count back, you can take a provisional decision. If it's largely lymphocytic with a normal sugar, then it's unlikely to be a bacterial process. On the other hand, if it's largely polymorphonuclear with a low sugar, then it is likely to be bacterial, and you can adjust accordingly. And finally, if your cultures grow, then you know what pathogen you're dealing with. And at that point, you should make sure you talk to the lab. If they are growing pneumococcus, make sure they give you the MIC, the minimum inhibitory concentration, so that you can classify it as a sensitive, intermediate, or resistant strain and accordingly pick your antibiotics. Obviously, if you have a lymphocytic CSF, you would be doing a PCR for herpes simplex, including PCRs for other viruses, and if that is positive, your diagnosis of herpes simplex is confirmed, you would continue acyclovir. Now, I mentioned that you would need to give a single dose of dexamethasone early on if you suspect bacterial meningitis, and this is why. There are studies showing that dexamethasone reduces mortality and hearing sequelae in bacterial meningitis, and this is most for pneumococcal meningitis. There is slight benefit and definitely no harm in meningococcal meningitis, but the critical point is you have to give the steroids before your first dose of antibiotic, and the reason is the first dose of antibiotic lyses many of these pneumococci, setting off an inflammatory reaction in the CSF, which in turn can actually cause the patient to herniate and causes lots of complications. So you need to preempt this process by starting it just before your first dose. And this is the recommended dose, 0.4 mg per kg per day. You only need to give it for about 48 hours or so. Recent studies have questioned the benefit of steroids, especially in developing countries and especially in children. So it works best in adults with pneumococcal meningitis. Certainly that first dose is important, and then when you make your diagnosis, you can decide whether to continue it or not. There is no role in meningitis for the following antimicrobial classes. This is very important from a stewardship standpoint. Meningitis is not an indication for broad spectrum therapy. This is very important. So there's no role for carbapenems, no role for quinolones, no roles for cephalosporins other than the standard third generation antibiotics which penetrate the CSF, the non-pseudomonal antibiotics like ceftriaxone or cefotaxime, and certainly the beta-lactam, beta-lactamase inhibitors are not recommended. In fact, they do poorly. They don't penetrate the CSF well in meningitis. The duration of therapy is also not prolonged. Pneumococcus, meningococcus are exquisitely sensitive, and the duration of therapy is roughly 10 days. For herpes simplex, you would need to treat them for 14 to 21 days, often repeating a CSF PCR to see if they have cleared by day 14 or so. What about the chronic meningoencephalitis syndrome? So whatever we talked about was in patients who have a history of less than 2 weeks. So what if the history is longer than 2 weeks? In that case, the differential diagnosis is somewhat different, and here etiologic diagnosis is the cornerstone. You don't have to rush in to do a CSF. You don't have to rush in to start antibiotics here. Here, careful history taking for a history suggestive of immune compromise, underlying HIV infection, exposure to specific pathogens, travel, all these things are critical. And CNS imaging is important. These patients would always need CNS imaging before lumbar puncture in order to make a diagnosis, rule out small space-occupying lesions, look for areas of enhancement, try to do MR spectroscopy if there is a mass lesion, etc. And following that, you have to plan your CSF examination very carefully. You need to remove large volumes of CSF because the diagnosis of tuberculosis or fungal infection requires a lot of CSF. Similarly, getting a cytospin, looking for malignant infiltration, requires a lot of CSF. And the most important differential diagnoses here are tuberculosis in a TB endemic country like India, Cryptococcus, especially in the immune-compromised or the HIV-positive host, and much less commonly malignant infiltration, for instance, acute lymphoblastic leukemia, sarcoidosis, and other autoimmune syndromes. And in this situation, we generally avoid antimicrobials, certainly till your imaging and all your CSF reports are back, because it is critical to establish a diagnosis here. Urgent treatment is not the need of the hour, as opposed to acute meningoencephalitis. Now, you might have heard of this cartridge-based NAT, nucleic acid amplification test. The most commonly used version is the Expert MTB, which is a nested PCR. It comes in its own kit. This is a critical test for TB meningitis because you can look at the sensitivities here pretty good, 68 to 70% against culture. And when they used a clinical gold standard, is still good, 55%. So WHO recommends this as a test of first choice for the diagnosis of TB meningitis. Two important points: take large volumes of CSF, at least 5 ml, centrifuge it down. And it's very important to remember that a negative Expert MTB does not rule out tuberculous meningitis because the sensitivity is only 55%. So if you have lymphocyte predominant, low glucose, high protein, subacute to chronic meningitis with a negative Expert, please consider empiric anti-tuberculous therapy because TB meningitis remains the commonest cause of this presentation. This is a paradigm which tells you the approach to these patients, especially where HIV is endemic, where the two most important tests you do are a peripheral cryptococcal antigen followed by CSF. On that CSF, you do both experts as well as a CSF cryptococcal antigen test through a lateral flow assay using large volumes and centrifugation, and based upon those results, you would make a diagnosis. Cryptococcus you always treat after diagnosis. If your Expert is positive, it confirms TB meningitis, but if it is negative and you've excluded Cryptococcus, a trial of antituberculous therapy is still recommended because of the imperfect sensitivity of all tests for TB meningitis. There is a recent advance in this area. A new version of Expert MTB called the Expert MTB Ultra has been rolled out. This is more sensitive. So it's even more sensitive than Expert MTB, and you will raise the likelihood that you will pick up TB by using this test. But this, once again, is not a 100% sensitive test. So even if you have negativity on this test, you may still be dealing with tuberculous meningitis. So, although we have Expert MTB, although this is available, once again, this is not a rule-out test. It is still a rule-in test. It is important to keep that in mind even when using these newer diagnostics. In conclusion, meningoencephalitis syndromes may be acute or chronic. If it is acute, you're usually dealing with a pneumococcal meningitis or a herpes simplex encephalitis. Rarely in India, you can have scrub typhus. If it is chronic, you're usually dealing with tuberculous meningitis, but remember cryptococcal meningitis in the HIV-positive host. CSF exam and proper planning of tests is critical in making the diagnosis of either acute or chronic meningoencephalitis. The therapeutic approach towards these patients requires a combination of pneumococcal therapy with both ceftriaxone and vancomycin, with coverage for, say, scrub typhus with doxycycline, and an antiviral for herpes simplex with acyclovir. And when you get your CSF parameters, you narrow down your therapy and give the patient the appropriate agent based upon the diagnosis. Thank you.